You know, there are two blessings in life actually, two blessings in life. Number one, for a father to be beaten by your son. And number two, as a teacher to be beaten by your student. These are things that are gifted to you by the good that you do. Many years back, as an undergraduate student in the Kasturba Medical College in Mangalore, we had a cementing individual, my classmate Satya. He was the cement for the batch because all of us, he got us together, so much of laughter, mirth and academics. Who knew? Of course, Satya evolved into a good orthopedic surgeon, went off to Puttur to take over his father's hospital and became an eminent orthopedic surgeon there. As the years unfolded, what did I say? To be beaten by your son. His son branched off again into orthopedics and then refined himself to be a spine surgeon. To be better than your dad and to focus on one particular area and be the best, we have Dr. Srihari Rao, and he finished his spine specialization and later on joined our group, the AJ Institute of Medical Sciences, as a faculty. It is indeed a privilege and an honor to be sitting here with you, Dr. Srihari, for a person of outstanding excellence, and it is my privilege and pleasure to introduce you to the August gathering, and he will share with us how does one become a spine surgeon, what are the areas of specialization, what are the critical things that come across you, and for a patient point of view, you know, to be under the knife of a doctor is something everybody fears. What can we do to prevent that? You know, all these and more, Dr. Srihari will share with us. Yes, sir, to you.
Thank you, sir. Thank you for welcoming me. I am, like sir introduced, Dr. Srihari. I am assistant professor in Department of Orthopaedics, AJ Medical College. My area of specialization is spine surgery. I mainly deal with the disc pathologies. So we commonly come across disc prolapse as the common complication, and we also deal with so many osteoporotic fractures also on a day-to-day basis. So that is my area of specialization. Now if you see, previously orthopedics was one branch. Now it has developed into multiple branches. This is because of the advances in the field of surgery. So now hand is a separate branch, likewise spine is a separate branch, arthroscopy, that is sports surgery, is a separate branch, arthroplasty is a separate branch, pediatrics, like that there are so many specializations in orthopedics. So what we do is we take up one field and try to excel in it so that we can give the best results for our patient. So that's what we do. And I landed up taking spine surgery because what I found is, after my MS, I was actually working in a government setup and I used to see the patient profile. Every other patient who walks into orthopedic OPD had low backache. Every other, that is every next patient is a low backache patient. So I decided I should be taking up spine surgery in order to understand the pathology of low backache and to treat it in a proper way. That's how I went into the field of spine surgery. That's
and how does, after MS orthopedics, how do you channel yourself into spine? There are centers that train exclusively in that. How is it? How is the pathway?
So now we have many types of fellowships, sir.
Yeah.
So one is actually company sponsored fellowships.
Yeah.
So usually the implant companies give a 6 months fellowship, 1 year fellowships.
Yeah.
Then we have university fellowships. Those are the ones given by Rajiv Gandhi University.
Oh yes.
So mine is Yenapaya University.
Oh.
Then we have something called FNB, that is Fellowship in National Board.
Oh.
That is given by the National Board, which conducts the DNB exams and the NEET UG/PG exams. So actually, if you ask me right now, the best field is FNB. FNB gives the best specialization.
And you secured yourself into the Yenapaya University and took this spine fellowship?
Yes, sir. I joined as a spine fellow 2 years back. 2020 I joined. Then I finished by 2023.
How long does it last?
My fellowship was 2 years.
Sorry,
I joined in 2021, finished in 2023.
Wonderful. And may I ask, because we have precious little knowledge because I am an ENT guy,
Yeah.
and what are the most common presentation conditions that you come across?
So on a day-to-day basis, what we see is commonly disc problems. So lower lumbar disc, usually L4, L5S1. This is a common problem we see. And the best part is actually 80 to 90% of the disc problems we manage conservatively. Only that 10 to 20% group of patients require some intervention. And those patients also, nowadays we have something called transforaminal injections. So we take the patient to the OT and we identify the root and we give a steroid injection to the root itself.
Oh, I see.
That's almost like a non-invasive procedure. So that's what I do on a regular basis. That's my,
and that relieves them the pain and misery and suffering.
That gives very good relief, sir. But there should be a proper indication.
Yes.
And there are contraindications also.
Yeah, it has to be done under ultrasonic control.
No, we do under CM guidance. So we have a continuous X-ray in the OT.
Like a CT, like a
CM is a continuous X-ray machine.
I see. That exactly tells you where you are injecting.
Yeah, we try to locate with the dye actually. We use a Omnipack dye. Omnipack is a iohexol dye. We give it to the root. Once we see the root exactly, there only we give the injection. And that gives very good pain relief. So that is the first step of treatment we do. But if still the patients are not getting relieved, then we plan for the next level of intervention. So most of the time, we put the patients on some medications, some nerve calming agents like pregabalin, or nortriptyline, duloxetine. So these things absolutely relieve the pain. If it is a small disc, usually a bulge or a protrusion. So there are 4 stages of disc prolapse. One is a bulge. One is a protrusion. Then extrusion and sequestration. So the first 2 stages you can manage conservatively, or you can give a transforaminal injection. So
and all these are done in our medical college, isn't it?
We do everything in our medical college.
No, it's a blessing for patients to come to the AGIMS, Institute of Medical Sciences, and get all these expert treatment, virtually almost free of cost. We get highly subsidized. Of course, we are indebted to the management for giving us all this.
But I'm actually very thankful for the management, because recently we acquired a microscope for our spine surgeries. It is a Zeiss Tivato microscope. So we are able to do spine surgeries in 1.5 centimeter incision.
I see.
It is like absolutely non-invasive way we are doing. And post-operatively, the patient will ask us, what did you do, sir? They will be surprised.
That's amazing.
So we are, that's what, lately, so previously there was a thought that if you put a bigger incision, you are a big surgeon. Nowadays it's quite opposite.
Is keyhole and everything.
Everything is a
but
keyhole
to get
surgeon.
That expertise is not easy too.
That's
That regard, I must say that indeed it's a privilege for us to have you as part of our team to be a spine. So certainly there will be hundreds seeing this particular presentation and wondering when are you available on a particular date. You have a date?
Our OPDs are on Thursdays. Because I am a part of 4th unit, orthopaedics.
So your day is on Thursday. If they want to come to the AGIMS, you are available on Thursday.
Thursday from 9 to 4 I will be available in OPDs.
Sometimes I wonder, nowadays it's like almost, as you said, everybody has a backache, and quite often the disc prolapse, and I have not much of an idea in these areas. But I come across terms like laminectomy. And can you tell us what is that?
Actually, this previously, what surgeons used to do is, whenever there was a disc problem, they used to remove the entire lamina. So one very great neurosurgeon used to describe like, the spine is like a engine. The spinal cord. And the lamina is like a bonnet. You have to remove the bonnet in order to access the engine. Now the problem is, if you remove the bonnet completely and throw it off, and you repair the engine will be fine. But the car body itself will become unstable. So that's what used to happen previously. They used to remove the entire lamina. They used to do a procedure called laminectomy. So the pain used to be relieved. But these patients used to come back with back pain later due to instability.
I see.
So that is because of the biomechanical instability. So the bony structure, if you destroy, definitely patients will end up with
Oh,
instability.
yes, yes.
So that's why nowadays what we do is
Yeah.
we do a small fenestration window. It's usually around 10-20 mm.
Yeah.
Through that we access the root. Then we identify the disc and remove without injuring the root. So that's a
Amazing it is.
surgery we do on regular
Amazing.
basis.
Now, a little bit for me,
Yeah.
I mean, we have the vertebrae. In between the vertebrae, we have the disc,
Yeah.
and then the disc is anchored in place by the lamina.
Yeah.
And but often I wonder, why is it like an epidemic? Everybody has a backache. Everybody is it related to? Sometimes I wonder, what is my sunlight exposure? Virtually nil.
Yeah.
Is it related to vitamin D deficiency or calcium or magnesium, or is there anything?
Definitely, sir.
Yeah.
I think lately what we are seeing is all
Yeah.
lifestyle related disorders.
Yes, yes.
And back pain is definitely a lifestyle disorder. So, like you told, sir, most of the people are working indoors.
Yeah.
So definitely the vitamin D3
Yes,
exposure
yes.
is very less.
Yeah.
So once you have vitamin D3 deficiency, your bone starts to fail invariably.
Yeah.
And one more thing is the junk food what we see on a regular
We
basis.
have precious little calcium coming into our dietary pattern,
Yeah.
or magnesium, or
Because of the junk food epidemic, we are coming across a lot of spine related problems. And the bad habits, especially the smoking and alcohol. They have done an extensive study on smoking and the changes in the disc in the Western literature. So they have found that if you are continuously smoking for around 10 years, that is a certain pack amount is there. Your disc will definitely degenerate.
Oh, I
they
see.
have proven also.
Oh, I never knew about all that. Oh, I see.
So because the disc is actually like a toothpaste material. So there is a toothpaste material like material in the center, and it is covered by annular fibers. So it requires a good amount of hydration in order to be fluid. What happens if you are not taking up your back, you are smoking or excessive alcohol? It loses its elasticity.
Oh, I see.
And it becomes a rigid structure. Then this toothpaste like material comes out and presses the root.
Oh, that's how it happens.
That's how it usually patient lands with the disc prolapse. So this is what we're seeing lately.
But once that happens, life can be misery.
And nowadays obesity is a very big problem.
Yes. That's another thing. So like we can consider like tomorrow you are going to build a home. You plan to build a 3-story house. Okay. And you put a foundation for 1 story. And you put 3-story up. So the foundation will inevitably fail. The same way, the spine has its own limit. It can take so much amount of stress. So if you put on too much weight, your BMI exceeds 30. I think definitely you will land up with they can't sustain the weight, and as a result.
And especially the lower lumbar spines. The L4, L5, L5, S1 will invariably degenerate. And actually it's very sad to say that. Latest we did one surgery for a 16-year-old boy.
My God.
So previously, actually, if you ask me,
was he overweight?
He was overweight. Disc problem is predominantly a disease of 30s and 40s in our textbooks. But nowadays we are seeing at 16 years and 18 years.
Oh my God.
That's I think what is alarming for us.
Parents actually should witness this video to realize the catastrophe that is unfolding in society nowadays.
Mainly I think it's due to that junk food. That's a major. The trans fats, whatever are there in your burgers, fries. Okay, if you eat it in a moderation, it's not a problem. But I think if you are regularly having it, it's definitely going to land.
Because it does not give the requisite nutrition.
Yes. And also lot of calories. So definitely the kid will land up overweight.
It's like an epidemic. Obesity has become an epidemic now. So if now parents are watching, what advice, and of course mothers and all, what advice would you give to preempt this possibility?
So mainly first thing is you should make the kids do outdoor activities. So one more thing we are
which
seeing
all
is,
they are only on video games
most
and
of the
nothing
kids
is there.
are indoor
Yes,
in
yes.
their PlayStation
Yeah.
or mobile.
Yeah.
Okay, most of the time,
Ah.
and they rarely go out.
Yeah.
So you have to make sure that kids have some kind of outdoor
So
activities.
in that regard, I must say, one day, of course, I had the good fortune to go for a visit in China. We were staying on top of a hotel on the upper floor, and below there was a school. At about 7 o'clock, the entire students came until about 9 o'clock. 9 o'clock, the entire school with the teachers, they came out into the ground, had a good sunlight drill for about half an hour's time every day. And I said, my God, isn't it time that we thought about these things in India? That awareness of contribution towards health is largely missing.
That is there.
And early, some of my early lecture, I used to insist, not actually 40 or 50, you must have a vitamin D level of 80 nanogram per deciliter. Who has that? When we do routine screening, it's hardly about 10 or 20, and that is quite alarming. Because imagine early years, hundreds of years, we go to the forest, chop wood, hunt animals, how much of sunlight exposure? Today it's hardly not even 1 minute. From my underground
one
parking.
One more thing is like, I am a vegetarian. So if you are a vegetarian, definitely you will have vitamin D3 deficiency.
So would you advocate at least once a year to screen for vitamin D levels?
I think it's very helpful.
Yes,
at least once a year. After your 40s.
At least once a year to. Now, what I have come across, I am in America, I believe after 45 or so, every female must have what is called a bone mineral scanning, of which I have precious knowledge about. Can you tell us a bit about what is bone mineral scanning?
So this is a very common problem we see on a day-to-day basis. So osteoporosis. So osteoporosis means the bone becomes more porous. Thereby it goes into fragility. So usually we see it in women after the menopause. So in Western countries, if you see, the hormone replacement therapy is a very important thing. But in India, it is not caught on well, actually. And lately, because there are so many stigmas for hormone replacement therapy. So this osteoporosis usually starts like 5 to 10 years after the menopause in females. And males, it usually starts like at the age of 70s. Like so in males, we call it as senile osteoporosis. Whereas in female, we call it as postmenopausal osteoporosis. And the first bone it usually affects is spine. Because the spine is a structure which takes so much pressure actually, if you imagine. So we have a upper girdle and we have a lower girdle. In between, the only structure connecting is the spine. So the amount of stresses the spine takes. So usually the postmenopausal female, the first common thing they will have is some back pain and some fractures, vertebral fractures. So whenever we get a old lady with backache, if you get a X-ray, you see multiple level fractures. Okay, that what we call codfish vertebra. Multiple fractures. We invariably think it is osteoporosis. Then we ask for a BMD DEXA scan.
What is that?
So DEXA scan is like a qualitative scan. So it's available in AJ hospital also. So what they do is they compare your bone with the normal bone of that age group. So it is a age matched bone thing. So they will have a quality and a control like that. So then they will give you a score. So if your score is less than minus 2.5 standard deviation, that means you are in osteoporosis. So this is actually a DEXA scan is compulsory, like you told, in Western population. Slowly it is catching up in India also. I have many patients who come to my OPD. They themselves ask me, should I get a DEXA scan? That's one.
Even as doctors, I'm not really aware of these things. But like that, is it necessary that every female after 45 once a year get a DEXA scan?
Definitely. So like you told, sir, I think the DEXA scan at least after your 40s, once a year is very important.
And when that shows deficiency, I mean, I sort of focus on calcium, magnesium, selenium, tin, nickel, manganese, molybdenum. Are all these required or just calcium is enough?
No, lately they found that calcium with the magnesium is important. With the vitamin D3 as well.
Oh.
So these are the three important things. But if you diagnose the patient with osteoporosis, then the management is totally different.
Yes.
So nowadays we have injection like teriparatide. Teriparatide is a parathormone analog.
Oh.
And we have something called denosumab. Denosumab is a monoclonal antibody. So this actually in my practice I use only these two injections.
What are they?
So they actually increase the bone quality. They are osteoclast inhibitors. Thereby they increase the bone density.
Oh, I see.
So I use it in my regular practice.
That's to be given once a week, or how?
Like teriparatide, usually it's a daily injection, subcutaneous, just like our insulin injection. Whereas denosumab is once in 6 months injection we use, and that is actually gives very good results for the patients. So in my practice I make sure I give this injection on regular basis.
The public is not really aware.
So many patients come to me, like they tell me that I had gone to other doctor, he started me on calcium, vitamin D3. I think once you are in osteoporotic age group, then you put on calcium, D3 will not work. Because even if you take 500 mg elemental calcium, only 100-150 gram will absorb. Then next day it will be going in the so once you diagnose patients with osteoporosis, the management is totally different. So that's why you need to take a consultation once you have a BMD minus 2.5 below the standard deviations.
So looking at the rampant epidemic which is happening, am I wrong in asking people take one calcium tablet with a little bit of vitamin D for life? People say maybe you are causing kidney stones. I said take 2 liters of water, probably it will avoid. But looking at the paucity of calcium in the diet and looking at the brevity of sunlight exposure, isn't it required that everybody?
I think if you are having a well balanced diet,
then these are not required.
Then calcium may not be required. But the problem is most of us, we don't have a well balanced diet. And the vitamin D3 especially, sir, the sunlight exposure, usually we say from 6 to 7 a.m. Because after that, if you go, you can have UV related complications. You can have skin problems.
But in that time, children are fast asleep or getting ready for school. And maybe many of them through vehicles, underground parking directly into school. Where is sunlight? Almost absolutely negligible.
One more alarming thing is doctors. Most of the doctors are having vitamin D3 deficiency. Because we usually go to hospital early morning. And we come back late in the night. So I think we doctors have to be careful. And I request all the doctors to check your vitamin D3 levels.
With the blessings of the management, maybe we'll have a sun deck where we'll have about 11 o'clock a break, spend about 15 minutes in sunlight. I don't know whether that will be...
But again, 11 would be
that will be too late a time.
You will have UV problems.
So we are in for big trouble, isn't it? The way we are converting ourselves from the actual jungle to the concrete jungle. And in that regard, of late the chairman asked me, you know, we see so many cases of cancer, and that perhaps also is related to deficiency of vitamin D, because it absolutely acts preventing cancer. I was not aware. It's only when he asked me I didn't know, but later when I went and scrutinized, I found that vitamin D also prevents most cancers from happening.
It has many metabolic properties, anabolic, catabolic properties as well. So that's why vitamin D3 is very important for us.
Now, some words only words I know, but I do not know the depth of it. Arthrodesis. What is that?
Arthrodesis is for the knee joint.
You actually fuse a joint together.
So if usually if the patient is having tuberculosis of the knee joint.
But in the spinal cord, do you put a rod and fix it, or
so what we do is we put a pedicle screw. So pedicle is the strongest part of the vertebra. So we put screws into the pedicle and we put a rod and we fix it. So that is called pedicle screw fixation.
For what is that?
So that is for osteoporotic fractures. So once you have fracture, the behind the bone is a spinal cord and the thecal sac. Now most of the time we need not operate. But if this fracture is pressing over the spinal cord, then the patient will have some
sciatica
deficit, neurological deficits.
Oh.
Then that is an indication for us to do the pedicle screw fixation.
Oh.
So that we decompress the spinal cord.
Oh.
This is the regular surgery we do.
Oh. In which that is a permanent thing, isn't it?
Yeah. Usually, I mean, if it's a patients are young, you can remove the implants after 1.5 to 2 years.
Oh.
But in older individuals, we don't remove.
Oh. Is there a risk, for example, I mean, they can't undergo an MRI? I'm not aware of these things.
Most of our spine implants are titanium.
Titanium.
Always titanium. Because if the patients come up with the adjacent segment disease. So what we commonly come across is we fuse L4, L5. After 4-5 years, patient come with backache again. So then they will have L5, S1 problems. That's called adjacent segment disease. Then you have to evaluate the MRI. So most of our spine instruments are titanium.
And MRI does not pose a risk.
No, doesn't interact with titanium.
Oh, nice. But earlier you were using iron, or was that?
I think in olden days they used to use steel.
So because of the junk food and the lack of sunlight, isn't it necessary that everybody be cautious and careful, and at least once a year have a routine scrutiny of their calcium and magnesium and vitamin D and take precautionary measures to avoid all that, because once trouble starts, it can be really major problems, no?
So I think if you are plus 30, plus 40, definitely get a vitamin D3 test. It will hardly cost you 800 rupees.
Yes.
And
what is your minimum that you would tolerate?
I think at least about 12, 14 is a good number for us. Less than 10 is very bad.
The problem is, my children are settled in Ireland, and they had the thing tested, and they were 6. I was shocked to see that, because virtually zero sunlight, and I said it's so horrifying to learn when I am advocating at least 80 nanogram, and here you are at rock bottom. So these countries where almost nil, they better be careful. So this is a very big problem. Actually, the WHO has also taken note of it. And that's why they are supplementing vitamin D3 to the edible oil. Oh, that way.
Like all the oils, essential oils. All the food substitutes they are doing. At least in minute quantities, they are giving it to the population.
Oh, that's a wonderful thing, because there's another major concern I have, because my mother had terrible gastritis, and then she used to take rabiprazole. I asked her not to, at least on a regular basis. Then she was almost like addicted to it. I believe that caused severe osteoporosis, and then later she had a spine fracture, she was in agony and suffered very badly. So won't you caution patients not to touch it at all, maybe?
I think this PPIs, proton pump inhibitors, there are some studies which have shown that it doesn't allow the magnesium and the other elements to get absorbed. Especially the magnesium, selenium. Calcium will get absorbed, but this micronutrients, they don't get absorbed. And on a long run, patients can develop osteoporosis. There are some literature.
My mother is an example, how badly she suffered, and later on, of course, she had a second fracture again and passed away as a consequence. So I know I am sort of deviating a bit, but whenever hyperacidity patients come, I simply avoid these. I only give olive oil, which the American College of Gastroenterology, they say olive oil is the best. It forms a nice coating and flushes off the helicobacter and is a better treatment. So therefore, these proton pump inhibitor medical rep fellows won't even look at me, because I am not a good market for them. But the nature's answers are there, instead of going on for these drugs, and that's how it is. What would you advise the junior doctors who are training? I used to early, as a vice, we used to medical education, organize a career planning for interns, and orthopedic as a specialty, and thereafter going into spine. Now, I have precious little knowledge about the various subdivisions of ortho. Like in ENT, we have head and neck, we have skull base, we have endoscopic sinus, we have rhinoplasty, we have voice, and general ENT. So like that, what are the subdivisions in orthopedics, and what is the potential for spine as a career choice?
Actually, so previously many people used to take orthopedics thinking that it was an end branch. So people used to think pediatrics and orthopedics are end branches. But I think it's no more end branch. There is no end to it. Because like so many branches have come. Like in orthopedics, the mainly one is the joints, arthroplasty. Then is the sports medicine. That is all your baseball injuries, all those. That's a separate division. Then we have spine surgery. Then we have hand. Then pediatrics. Then we have orthopedic oncology. Orthopedic oncology is also one more separate branch. Then we have foot and ankle. Foot and ankle. So these are the broad specialties. And we have newer and newer branches coming up. In spine, if you ask me, there are divisions again. So one division of spine surgery is deformity correction. So where we deal with kyphosis, scoliosis of the spine. So pediatric deformities usually deal with that. Then the other division of spine is MIS spine. That is minimally invasive spine surgery. So now that is also again divided into microscopic, endoscopic. So I am a microscopic surgeon. So but now the latest advance is endoscopic surgeries. So whereby you put an endoscope into the lamina and identify the root and the disc, then you do a discectomy. So this is the latest advance actually.
This is far beyond our idea.
In that also there are different approaches. You have something interlaminar, you have transforaminal, you have biportal. So there are subdivisions. There is no end to it. So
as science evolves,
So I think if you want to take up orthopedics, it's one of the very good branches. But I advise the students who are taking, it is not an end branch. I think if you definitely have the passion for it, you have to go for it. But like you told, it's a never-ending branch.
True, but in whichever discipline eventually you land, make sure you are the best in the world.
That I think
so much so, the world should come to you.
So you should not be jack of all trades, master of none. It should be a master of one.
Absolutely one.
Then
and
only
be
will
the
succeed.
best. Is it difficult? No, it's not difficult. Because once you're the best, the world should come to you. And that's what is happening to Sri Hari. Because I've seen patients from all across India are now gravitating, thanks to the untiring support of the Vice President of our college, Mr. Prashant Chetty, to whom we owe our gratitude, because whatever equipment and machines that you ask, he sanctions.
So we are very thankful for the new microscope what we got, and we have been doing many surgeries under that.
That is why perhaps we have leapfrogged our other institutions to be the leading cutting edge of technology and techniques. And with you at the helm of spine surgery, we are going to go a long way ahead. It is indeed a fantastic morning, huge amount of knowledge, and you have opened a window to our minds. It's been so kind of you to come and share your wealth of expertise with us. Thank you so very much. And I call upon Ms. Akshata to give a certificate of appreciation for his coming and sharing his time with us.